Hello, and today we're going to be talking about alterations in pregnancy. So this lecture is going to focus on the various things that can occur during pregnancy that are pathophysiologic in nature. The first one we want to talk about is adolescent pregnancy. And while this isn't necessarily pathophysiologic, like I just mentioned, there are some special considerations with this age group when we think about pregnancy. We know that teens participate in high risk behaviors and not always understanding the consequences of their actions. In addition, we know rates of teen pregnancy have declined, but they're still there and will probably always be there. This slide kind of just highlights some of the considerations for teenagers and having children during adolescent timeframes. That bottom corner where it talks about finish high school, get a job, and get married before having children, you have a 98% chance of not being in poverty. So that also shows that flip side, that having children while you're in high school, maybe not finishing, some of those things can contribute to a higher rate of poverty. So just gives you some statistics there that are pretty eye-opening and kind of points you back to talking about abstinence or contraceptive with those ages. Some of the concerns with adolescent pregnancy, there's a lot of physical demands on the body. As a result, there's a need for early prenatal care to decrease risks. However, adolescents aren't always willing to seek prenatal care early. They have an increased risk for preterm birth, low birth weight infants, preeclampsia, anemia, and CPD, which is cephalopelvic disproportion, meaning that the head of the fetus is disproportionate in size to the pelvis of the mother. They are needing to support their growing fetus as well as their own growth spurts. And they're at a higher risk for STIs, which can also complicate the pregnancy and the fetus. So lots of this is going on. We know that we have to think about the stages of development that these teens are already in. So there's some stages, we talked about the Rubens test for motherhood, but these teens are also going through some normal psychological development tasks within their adolescent years. And so extraordinary amount of development that needs to occur from a psychological perspective. They need to make decisions on what to do with the pregnancy. Are they going to parent the child, place the child for adoption, think about an abortion? There's some significant considerations. There are different laws or restrictions by state regarding the adolescent's ability to make these decisions for herself, or do parents need to be involved? As seen on that other slide just before, there's also lifelong social and economic disadvantages for these individuals. Teens tend to have a it won't happen to me mentality. So their consequences of their actions aren't always truly understood. So unsafe sex practices or not using birth control are more common because they do believe that it wouldn't happen to them. What does our nursing care look like for these minors? So we really have to think about nutrition. Because we know that they're meeting their own growth spurts and they need to also be providing for the infant, we really need to monitor nutrition as well as fetal growth and movement. Teens tend to eat very sporadically, maybe skipping meals, not eating regularly, not sleeping regularly, and that can all impact that fetal growth. So assessing for that, being sure that we're assessing for STIs, and then educational needs. So what needs do they have to prepare for the decision that they're making regarding the pregnancy, if they're going to parent the child or give the child up for adoption or any of those. So making sure that we're meeting all of those educational needs. The link there does give you an overview on some of the parental notification or what minors can consent for, and we'll talk a little bit more about that in class as well. Some of the things we know we're probably going to be doing. Talking through a physical exam. These adolescents may have never had a gynecological exam before, so that's going to be, they're going to need some reassurance. They may want their parents included, or they may not, but following through on their desires in that, being non-judgmental when you're talking to them on making decisions, and try to not influence or put your values onto them, project your values. Another consideration, there's going to be some parental conflict over values. Teens maybe have difficulty in disclosing the pregnancy to their parents. They might be hesitant. Some of this varies by age. Younger teens, 13, 14, are actually more likely to disclose than older teens, like 16 or 17, who have a little bit higher level of independence. They're able to drive. They might seek care on their own, versus those younger teens who are still much more reliant on their parents. On the flip side, we have these women over 35 who fall in this age group of advanced maternal age. And again, while not pathophysiologic, it is a consideration in pregnancy because it can impact the pregnancy. Some of the changes that are occurring in that age group, we do see that pregnancy in this age group is more common than it was in past decades. Many women are choosing to have a career before they focus on children and are starting families later in life. As we know, there is a decrease in fertility as women get a little bit older, so that can impact their ability to have children. There is an increased risk for Down syndrome in this age range, and as well as a higher incidence of other complications and pre-existing medical problems that will further complicate pregnancy. Again, they have an increased risk of preterm labor and birth. A good chunk of the nursing care that is different for this age group, they may fall into that high risk. So they're going to be monitored a little bit closer during the pregnancy and have more frequent office visits. And then we're also going to provide some education on screening for genetic disorders. In addition to this age group, will be offered in amniocentesis generally to look at those genetic disorders because they are at an increased risk. So you'll be providing some clear education on those components. Now we're going to move into some of the pathophysiologic conditions. And the first one I want to talk about is gestational diabetes. In order to really understand gestational diabetes, we first have to think about what's going on in normal pregnancy related to insulin and glucose. So we know that insulin production is increased in the second half of pregnancy, in a normal pregnancy. So that's good to keep in mind when we think about diabetes. There is some slight peripheral resistance to insulin in a normal pregnancy to continue to push the glucose to the fetus, because the fetus needs a lot of glucose. So that kind of helps to push that glucose towards the fetus. In addition, there will be a little bit decrease in peripheral uptake of glucose as a result of that resistance. So there is a little bit more fat metabolism during pregnancy. During the pregnancy, the insulin demands are lower in the first trimester, a lot due to nausea and vomiting, and they rise late in the first trimester, right as that second trimester is beginning, and they increase further. They increase during the pregnancy, and then they increase even further in labor, and then they drop after that placenta is delivered. In the diabetic pregnancy, so this is somebody whether that was pre-existing or they become diabetic during pregnancy, their insulin demands will vary. And that's where we kind of, just as I talked about, they're likely going to drop in that first trimester and then increase in the second and third. Ketoacidosis can occur at a lower threshold than non-pregnant, so they are more at risk for developing ketoacidosis. And during pregnancy, they might have some increased vascular complications as a result of their diabetes, so those considerations are more common during pregnancy. So what do we need to try to do? So the best thing as far as pregnancy outcomes is really focusing on good metabolic control without hypoglycemia. We really want to avoid that hypoglycemic condition because that can further complicate the pregnancy. We do know that there are some more risk factors with these women. So they are more likely to have hypertension. They're more likely to have a high level of amniotic fluid or hydramnios. Ketoacidosis is more at risk. Because of a woman with diabetes in the pregnancy, that glucose is running high. So while we know the fetus needs a lot of glucose, those infants of a diabetic mother are getting more glucose than they need. And so as a result, they tend to become large for gestational age, or that LGA. So that macrosomia, or that large baby, can create a difficult delivery and some dystocia problems. So that's one of those challenges with those women. There is a risk for some congenital anomalies that seem to only occur in infants of diabetic mothers. If there are some vascular complications as a result of the diabetes, there might be some IUGR, or intrauterine growth restriction, meaning that the placenta is not perfusing well because of that vascular involvement, and so baby's not going to be able to grow as well. And while these infants may be large, they tend to be more at risk for jaundice because they're large, but they're not necessarily mature. So their liver tends to be immature, and their lungs as well might be a little bit immature. So they do have a risk for jaundice as a result of that. So how do we screen for gestational diabetes? So care related to diabetes is the same whether they were pre-existing or developed during pregnancy, but how do we screen for development of diabetes during pregnancy or gestational diabetes? So we have to look at the timing of the screening first. And that really varies depending on a low risk or a high risk category. So if they're low risk, so most pregnant women will be screened around 24 to 28 weeks gestation. If they fall into high risk, they're going to be screened as soon as possible in the pregnancy, so very early with if we identify them as high risk. And the things that might put them as a high risk category include a history of gestational diabetes in a previous pregnancy, or a history of a large for gestational age baby, looking at generally over 4,000 grams or 4 kilograms. Obesity would be high risk. PCOS, or polycystic ovarian syndrome, because there's some insulin resistance with that syndrome, and those individuals are more at risk for diabetes. If they have some of that glycosuria or glucose in the urine, or a strong family history of type 2 diabetes. So anybody with any of those risk factors would be screened earlier in the pregnancy. And screening tests. So the hemoglobin A1C, if it's done and it's over 6.5, it would be diagnostic. However, if we think about pregnancy and for those low risk people, we're going to screen between 24 and 28 weeks, or we're looking for a new onset of diabetes, that hemoglobin A1C is not always the best test because it doesn't identify the new onset because it's looking over a period of time. So it may not have become abnormal yet. So this glucose tolerance test is the most common test used during pregnancy. And it's usually a 1-hour test. So we see how the pregnant female tolerates the glucose load at 1 hour. And if that 1-hour test is abnormal, then they would go on for a 3-hour test. And if they have 2 or more elevated blood sugars as a result of that 3-hour test, they would be diagnosed with gestational diabetes. In a 2-hour test, they would evaluate at 1 and 2 hours, and if they're positive at both of those times as far as an elevated glucose, then that would be diagnostic. So we're looking for those high glucose levels over time in a response to a glucose load. So what are we going to do? So if they've been identified as gestational diabetic or pre-existing diabetic, we're going to be doing some additional fetal screening. So an ultrasound, because we know there are some risk factors with a large baby or a congenital anomaly. So we're going to be monitoring that and looking at that. Amniotic fluid, we're going to be measuring that to see what is there too much fluid as a result of that. Fetal activity to make sure that baby's moving well, and then because once diabetes has developed, then this woman becomes a high-risk pregnancy, they're going to be monitoring using that non-stress test and monitoring for fetal well-being through that non-stress test. There also is some considerations regarding timing of delivery. So we know there's a risk that this baby could become larger, especially if the blood sugars aren't well controlled. But the risk of respiratory distress syndrome or hyperbilirubinemia because of the immature lungs and liver can be a concern. So we kind of have to, they're going to balance those out. But we also have to monitor for that placental concern if there's some vascular complications. So really looking at it and balancing all of those things together to ensure a healthy mom and a healthy baby. In pregnancy, there are also many other alterations that we want to think about. First, let's talk about anemia. So anemia can be related to a couple different things: iron deficiency or folic acid deficiency. So iron deficiency anemia is what we might see most common, and this can occur in 1 in 4 pregnancies, and with onset either occurring before or after the pregnancy. So somebody may already be anemic and the pregnancy might complicate that further, or they may develop iron deficiency anemia as a result of that normal physiologic anemia kind of decreasing too far. The risks with anemia relate to fatigue, infection, an increased risk of postpartum hemorrhage and preeclampsia, low birth weight in the infant, prematurity, or stillbirth. So to try to prevent this, we really want to look at that prenatal vitamin that includes 30 milligrams of iron per day, and that's recommended for all women to try to avoid this iron deficiency anemia occurring during pregnancy. Ferrous sulfate's the most common form of iron that's given. So diagnostic ability to see if there's a hemoglobin less than 11 or a ferritin level less than 12, then that would be diagnostic of iron deficiency anemia. And if they're diagnosed with anemia, we're going to increase that iron supplementation to around 60 to 120 milligrams a day. So while all women should be taking 30 milligrams to try to prevent, if they're diagnosed with anemia, it's going to increase to 60 to 120. Folic acid deficiency anemia is a little bit different, and this only happens in about 1 to 4% of pregnancies. Diagnostic is it's diagnosed with a very, very low hemoglobin, and it's often detected late. So we do know that this can really cause some neural tube defects. It also, women might have some symptoms of nausea, vomiting, and anorexia. However, it's diagnosed late if they do have a folic acid deficiency. So once a deficiency is identified, we're going to increase their folic acid dose to 1 milligram. However, it is recommended that all women of childbearing age take that folate or folic acid supplement of 400 micrograms to try to reduce the risk of this type of anemia. Most prenatal vitamins are going to have 400 micrograms of folate in them for this reason. Cardiac disease. So this is looking at complications from pre-existing cardiac disease, whether it was known or unknown before the pregnancy. So in this, we know it is not very frequent, less than 1% of pregnancies, but early diagnosis and close follow-up is very, very important for these women. And we talk about this because this, while it's rare, less than 1%, it's the 4th leading cause of maternal mortality. So it is pretty important to think about. It can be from congenital or rheumatic conditions, but the results are really some of the same. So Marfan syndrome can also lead to some cardiac disease risks. What we're going to look at from a pregnancy perspective is what classification of cardiac disease. Are they class 1 or 2? And usually the pregnancy outcome in class 1 or 2 is pretty good. Class 3 or 4 cardiac disease tend to have more complications and they require more monitoring during labor, to the point that we really want those women hospitalized before labor even begins. If the female is needing any anticoagulation, heparin is a medication of choice during pregnancy because of the decreased risk of crossing the placenta and impacting baby. If they have CHF, the thiazide diuretics or Lasix would be the drugs of choice for that. So how do we care for these women? What are we going to be doing for them? And the big thing is monitoring for CHF symptoms. So we know they have cardiac disease. They're at risk for developing some heart failure. So those things that we're watching for, and you guys have learned about that in previous classes. Same things. CHF presents the same way, and we're going to be monitoring for that, for complications. These women are going to be seen much more frequently, usually every 2 weeks, and then weekly during the second half of the pregnancy when there are even more demands on the heart. Lots of education for them, making sure they're getting enough nutrition and protein, that they're side lying to make sure that the pressure is off of that vena cava, that they're getting enough sleep and rest so that they can support that pregnancy. And we also want to think about what's going to happen once that baby is delivered, because there's been this large increase in blood volume and water retention during the pregnancy, and now we need to excrete all of that. So there is some risk for decompensation during postpartum period as all of those fluid shifts are occurring. So that can also be a challenging time for these women with pre-existing cardiac disease. Substance abuse is another consideration that can be challenging during pregnancy and can create some ethical considerations as well to think about. What are some of the concerns because of this? So we do know that women tend to seek prenatal care late in these cases, or maybe not at all. It's their health and well-being and their primary prevention are generally very limited. They may have some reluctancy to disclose that they're using these drugs of abuse. So you might also need to be looking at signs of drug abuse. Maybe you see track marks or just some appearance or things that might lead you to be concerned. Maybe there's a history of drug abuse or children being removed from the home because of drugs. So looking at some of those signs or history that might lead you to want to evaluate a little bit further. Some of the maternal concerns for women that are abusing substances during the pregnancy. Going through withdrawal during pregnancy can be very, very challenging. So withdrawing from some very significant drugs takes a lot on the body, and that can be very challenging. Or if they continue to abuse during pregnancy and they're going through withdrawal during labor, that can really be challenging for that female. They are at risk for some additional complications potentially, like preeclampsia. As a result of some of these increased risks with withdrawal and things like that, there are some drugs that are better to be weaned slowly during pregnancy. So we really don't always want them stopping cold turkey. For example, heroin. It's very common. We hear about it all in the news. Very challenging withdrawal and very difficult on the mother. So methadone clinics are utilized by pregnant women because we really want to wean them slowly, because that actually decreases the risk factors versus stopping cold turkey. So pregnant women would be eligible for methadone and working through that withdrawal, because we keep a steady dose. We know there's some control over it versus the peaks and valleys that occur with heparin or heroin use otherwise. Some of the infant concerns. So what are the infants going to experience if they're born to a mother who's using substances? They're going to go through withdrawal, which could have some irritability, cause some difficulty feeding. There may be some lifelong learning difficulties as a result, and they may experience neonatal abstinence syndrome, which becomes an even more significant form of withdrawal. During the pregnancy, they may have developed some congenital anomalies, and they may also be at risk for being small for gestational age or have some intrauterine growth restriction because of the impacts of some of those drugs. Many of them will cause some vasoconstriction, which will decrease the placental perfusion and can impact baby's growth. Nursing care. So the biggest thing, we're going to be screening with maternal consent as needed, providing education, and then referring for assessment. So often we use a brief intervention in many community-based facilities. So it's really a form of talking to the client about how much they think they can cut back and what they think is reasonable to decrease their substance use, and allowing them to kind of guide those processes. There are many things that could contribute to bleeding in pregnancy, and we're going to go through several of these right now, and then again we're going to talk about some other ones at a later point. The first complication is spontaneous abortion. So spontaneous abortion means that the female is going to the pregnancy is not going to be viable, and it's commonly known as a miscarriage. 50% of these are due to congenital anomalies or incompatibility. So very commonly, these infants or these fetuses were not developing normally. Other reasons can be some of those teratogens, some faulty implantation, a weak cervix, insufficient hormones, chronic diseases, or hyperthermia from a hot tub. So that increase in temperature from that hot tub. We do want to think about what happens after a loss. And generally, if they've had one spontaneous abortion, pregnancy can be successful after that. But after multiple miscarriages, we become concerned about the reason. Do they have some insufficient hormones or a weak cervix that's going to continue to be a problem for that pregnancy? And then they might need some additional follow-up. Bleeding occurs in 25% of first trimester pregnancies. So a quarter of women will have bleeding, and only about half of those women will miscarry. So 1/8 of all the pregnancies. Some of the things you could expect will be done or ordered by the provider would be the provider might be doing a vaginal exam. They might order an ultrasound to look to see if the pregnancy is viable. And then they're monitoring the HCG levels. We expect that those would decline if the woman is miscarrying. And then also looking at the hemoglobin and hematocrit because of the bleeding. If it is a threatened abortion, so they've had some vaginal bleeding, and you see that in the first one, but the fetus is still viable, we would recommend bed rest and abstinence in that case. As opposed to an inevitable or incomplete abortion. So an inevitable means that the fetus is no longer viable, the membranes have ruptured, the cervix has begun to open, and the miscarriage is starting. So it will end up completing. And incomplete means that some of those products of conception have been expelled and some remain. So some of the tissue has not completely left the uterus. So we're going to kind of monitor for that. So if a woman has a miscarriage, we do want to make sure to give RhoGAM to those Rh negative moms within 72 hours. That's really, really important from a nursing perspective. And we'll talk about alloimmunization later on in this presentation. What are we going to be doing for that mother as a nurse? So primary assessment, we want to think about blood pressure, pulse, some of those things. We're losing blood, so we really want to observe for kind of shock or hypovolemia. We're going to look at how many pads are being soaked with blood. So what is that blood loss? So counting those, maybe weighing them, and saving any tissue and clots potentially. Assessing for fetal heart tones. So depending on where the pregnancy is, you might be trying to do for that. You may also be preparing for IV therapy. So she's losing some blood, so we may need to give her some fluids. You're preparing her for that vaginal exam, maybe giving some oxygen if needed, depending on her vital signs. And then looking at those psychosocial factors. That's a really, really big component. And later in the semester, we are going to talk about perinatal loss and how that impacts mothers from a psychosocial as well as families from a psychosocial perspective. The next thing that can cause some bleeding in pregnancy would be an ectopic pregnancy. So an ectopic pregnancy means a pregnancy that has implanted outside of the uterus. This occurs in about 2% of pregnancies, and there's many risk factors, and you can see those up in the corner on this slide. With pelvic inflammatory disease being the biggest risk factor. So those undiagnosed STIs that would further complicated and cause some PID. There can be some scar tissue. And if you look at all of those other things on those major risk factors, many of those are going to cause some scar tissue or some abnormalities within the reproductive system. And that is what really puts them at risk for that abnormal implantation. And then there's some minor risk factors, and again, those tend to not be as common as the others. But ectopic pregnancy causes 9% of maternal deaths still. So that's why it's really important to think about and work towards preventing or recognizing those risk factors. So what precedes maternal death? Why do we need to talk about this? So one of the biggest things that is going to occur is that we're worried that if that has implanted in the fallopian tube, that as that pregnancy grows, that tube could rupture. And if that tube ruptures, then there's a significant hemorrhage risk, and that would be really what we're concerned about as far as a risk for death. The tubal pregnancy, or that pregnancy that's implanted in the fallopian tube, that is the most common site for an ectopic pregnancy, and particularly in the ampulla of the tube. Ectopic pregnancies can occur anywhere else. They can occur in the abdomen or on the outside of the uterus or many other places as well. Differential diagnosis, because they present with pain. So pain in the adnexal area, maybe an adnexal mass. They might have some right shoulder pain. We might think about appendicitis, or maybe they're miscarrying a spontaneous abortion. Maybe they have an ovarian cyst. So there's some other things. Maybe it's a UTI. So we really have to think about what else could be going on, but not leave out ectopic pregnancy as a possibility, because we really want to catch it early if it is happening, so that we don't chance that ruptured tube. Other things that you could expect, so if a patient presents with some of those pain, or pain that might relate to this, is we're looking at that transvaginal ultrasound, looking at an HCG level to see what's going on with that pregnancy. Do we see an intrauterine pregnancy if there was a positive pregnancy test? What are the HCG levels? Is it doubling every 48 hours like it normally would, or is it abnormal and not doubling? And then lastly, how are we going to treat this? So methotrexate is a medication that can be given to essentially induce an abortion. And this would only be utilized if there's no fetal heart activity, so that it's already not a viable pregnancy. There is no heartbeat, the tube has not ruptured, and it's small, so less than 4 centimeters in size. So if the female meets those conditions, then they would give methotrexate IM to induce that abortion. However, if it's larger than 4 centimeters, or the tube has ruptured, or any of those, they're going to have to do surgery to treat, and your care would be related to the pre-op, post-op, knowing that they may have to remove the entire tube, and that can impact future pregnancies. So you may also have some psychosocial aspects to be talking about with those females. Another condition that can cause bleeding early in pregnancy is gestational trophoblastic disease. So gestational trophoblastic disease can also be referred to as a molar pregnancy. And this becomes a concern for a variety of reasons. So essentially what's going on in these is that the trophoblastic cells have grown abnormally. So in many cases, there's not even a fetus. It's really just a takeover of these trophoblastic cells that are continuing to multiply at a high rate. And we're going to look on the next slide. So these women are at risk for bleeding, uterine enlargement. There would not be fetal heart tones because there is no fetus. However, there would be a high HCG level, so they would have had a positive pregnancy test, even though there may not, there likely wouldn't be a fetus. So this is one of those cases that can demonstrate why you would have a positive HCG. This is diagnosed through an ultrasound, and we need to remove that abnormal tissue. So a dilation and curettage, or D&C, to remove abnormal tissue is a possibility. And we're also going to monitor some of these. So the biggest risk for this is development of choriocarcinoma. So we look at this risk for choriocarcinoma, and we have to look at what is gestational trophoblastic disease. So it's this abnormal tissue, and you can see the complete mole on the picture. So there's really just some abnormal tissue, and that is the most common. You see there's some partial where you could have a developing fetus, but also the abnormal tissue. That is very, very rare. We're going to focus on this complete hydatiform mole. So if we go down to the bottom, you see this invasive mole. So now this abnormal tissue, this trophoblastic tissue, has started to invade into the uterine wall. And so this becomes a little more of a concern, and a DNC likely would not remove all of that tissue. We can't just take out that abnormal tissue that's filling the uterus, because now it's actually into the uterine wall. And so that may require a hysterectomy, which can impact future childbearing for obvious reasons, for removing the uterus. The big thing that we're really monitoring for is that this abnormal tissue, this trophoblastic tissue, can become a choriocarcinoma. So trophoblast became the chorion. So this trophoblastic tissue, if it continues to develop into a cancerous condition, is called choriocarcinoma. And that would be, it's invading that uterine wall and has become a cancerous condition, which is why it's really important to catch this and remove that abnormal tissue early on. So what do we do if somebody develops choriocarcinoma? Likely they were going to need a hysterectomy, because you can see that that has invaded the uterine wall. But we also need to monitor for metastasized trophoblastic tissue. So the way to monitor for this abnormal, this METs in these clients who had choriocarcinoma, is this tissue secretes a high level of HCG. So these women who have a gestational trophoblastic disease, even if we haven't identified it as choriocarcinoma, need to go through some serial HCG levels for a full year to evaluate for development of choriocarcinoma, or to monitor for METs as a relationship with choriocarcinoma. And so if they were able to remove the tissue without removing the uterus, and choriocarcinoma was not identified at the time of the tissue removal, we still have to monitor that HCG for a year. So those women should not get pregnant for a year, because if they get pregnant, that HCG is going to rise as a result of the pregnancy, and we have no way to monitor for METs. So it's really, really important education for a nursing perspective to ensure that those patients understand the importance of waiting. Alloimmunization. So this is the last thing, and this relates to that Rh factor and the use of RhoGAM. So let's talk about this a little bit more. So Rh sensitization is really what we're trying to avoid in pregnancy, and this picture does a very, very good job of explaining what we're looking for. So this occurs, you have a father who's positive for Rh and a mother who's negative, and she's carrying an Rh positive fetus. So there's these Rh antigens from the developing fetus can enter the mother's blood during delivery, and we know that some of that will happen. This can also, some of those fetal cells can also cross the placenta, but most transfer at delivery or anytime there's bleeding during the pregnancy. Some of those fetal Rh positive cells could transfer into that mother. That's where we become concerned. So we want to avoid then step 3 here on this picture, where the mother then develops these anti-Rh antibodies. So those green antibodies that you see in that picture, because now that she's developed those antibodies, in a subsequent pregnancy, if the fetus is positive, those antibodies are going to attack the fetus and to damage those red blood cells in the fetus. So it can create some significant problems with future pregnancies. Fetal anemia can occur. It can result in some edema that because of that fetal anemia, and the fetus can develop CHF if that is going on. So we really want to prevent that. So we prevent it by preventing stage 3 from happening. So we know some of those positive antibody, or those Rh positive cells are going to be exposed. The mother's going to be exposed to those. So we need to make sure we give her this Rh immune globulin, or RhoGAM. So this is given to all women at 28 weeks of pregnancy if they're Rh negative. And then there's a couple other times. So we give it to a woman who's Rh negative at 28 weeks if she has any bleeding during pregnancy. So that's miscarriage risk early on. If she has an invasive procedure like an amniocentesis that has a bleeding risk. If she has some bleeding later on in the pregnancy, she would need to have that RhoGAM shot, because anytime there's bleeding, there's a risk for those cells from the fetus to cross. And then again after delivery, because we know that many of those RBCs transfer at the time of delivery. So after delivery, if they test and baby really is positive, then mom would get another injection within 72 hours to prevent the development of those antibodies. If they test baby after delivery and baby happens to be negative, then mom wouldn't need that. But we don't know that during the pregnancy, so she would still get the RH immune globulin during those other times. The other question that often comes up is, what if dad is negative? Or my husband's negative. And again, we don't know that. We don't know who the father is. We can't make that decision. So generally in practice, we providers tend to we give the RH or the RhoGAM to all women who are negative based on those following our parameters we discussed. So what if she received RhoGAM, went well, didn't develop those antibodies, she becomes pregnant again. So this isn't her first pregnancy, but she still needs RhoGAM, right? Because we still want to prevent her from developing the antibodies in that pregnancy too. So it's a continual process. We really want to always give that to prevent that sensitization that can cause some complications in future pregnancies. And that is all for today. Thank you for listening.